Um, Now let's continue with the live case because yeah, we have the information that Professor Vauchev is done with the first case.
Hello everyone, can you hear us? Can you hear us?
Hello, guys.
Hi, Vasco.
Do you hear us?
Yes?
Hi. Um, what we are presenting for you today is a relatively simple case of a lady with arm claudication and critical subclavian stenosis. And I will just shortly present my team. Here with me is Dr. Jennifer Anja, our nurses Genkova and Tilkova, and we have some few pictures for you just to see what is the prehistory. Jim?
Okay, so hello everyone, it's an honor for us to present a live case from St. Anna Hospital. We have a 64-year-old female patient. Next slide, please. For the last 5 to 6 months, she had numbness and weakness on her left arm while working. That's why she visited a neurologist, and after excluding a neurological problem, she was sent for a angiology consult where she was found to have a difference in her blood pressure in both arms, so 140 over 80 on the right arm and 70 over 40 on her left arm. As risk factors, she has only dyslipidemia, she doesn't have diabetes, and she doesn't have a smoking history, which is interesting. And she was sent for CT angio and given a combination therapy of rosuvastatin and ezetimibe. Next slide, please. This is her CT angio, and you can see the proximal part of her left subclavian artery has a critical stenosis. Another interesting thing is that her left vertebral artery doesn't come out of the subclavian artery, but rather directly from the aortic arch. Next slide. The next slide, please. Yeah. Here, the image is the other way around. So on the left side, you can see better her left subclavian artery and the stenosis. And this is it as previous studies. And now we're going to show you the angio that we did just 2 minutes ago. And
James, just a few words about what we are planning to do. Gentlemen, what we are planning to do is a relatively straightforward procedure. In our experience, we would like to predilate but with a drug-eluting balloon because we think that restenosis is not so infrequent in this situation. So what we did, I will follow a few steps. First of all, of course, you puncture under the fluoro control, and then we took just a picture of the femoral because we plan to go for the closure device after. And then we introduce our destination 6 French sheet, and the pictorial is showing to us that this still stenosis and not an occlusion. So what we did next, we took our diagnostic vertebral catheter. Very easy and softly, we went through the stenosis with 0.18 V Boston wire. And now we approach the stenosis with the destination sheet. Now we're going to film it for you. So what we plan now to be with the underside 6 millimeters balloon to predilate, just to check the compliance of the lesion and to have some paclitaxel inside, and then we are going to put a balloon expandable stent. Do you have any comment?
It sounds like a great plan. Why antegrade approach? Why not retrograde?
Because our experience that if you go with relatively big profile devices through a slender radial, most of the time you end up with a lot of pain in the arm, and radial is for comfort of the patient. So we believe that femoral is more comfortable for us and for the patient, and having a closure device opportunity is not a big problem to close the puncture.
And what about brachial instead of radial?
Brachial.
What about brachial instead of radial approach?
Brachial. You think that brachial have less complication than femoral?
Not really, yeah.
In our experience, we think that femoral, at least we are more convenient than femoral. We can do it brachial. Usually if the setting was for recanalization, it was total occlusion, we would rather go for both brachial and femoral, but in this situation we have a simple stenosis, and that's why we prefer to keep it simple. Can I have the balloon, please? Шестица, да. It's a relatively straightforward case in our experience. The restenosis in this situation is something like 10 to 15%. And because the lady is symptomatic, she got a claudication of the hand. We believe that having some paclitaxel on board will give us better chances to get away with the long-term result with the restenosis. It's not proven for this location, but at least what we know from the other location, we believe it's properly done so. So we are going to put a avascular luminor drug-eluting balloon inside. Yeah, it's 6 by 40. There is no calcium in the lesion. So that's why we think that predilation with a regular balloon in this situation is not needed. But we're going up with the inflation very gently, softly, and slowly, and we'll see the compliance of the lesion.
Do you think it's kind of a soft lesion? I mean,
I don't know, to be honest, but I don't see any calcium on the CT, and there is no any calcium on fluoro.
No, my question is actually if you had a vertebral artery, which you don't have. Is there some
you have
cases?
Some problems, you see?
Yeah. Is there some cases that you would protect the vertebral artery?
In this situation, our vertebral is coming with a separate osteum out of the. Even in case we have a vertebral in a typical position, we don't protect it. Go with the balloon, please. We go slowly to 4 atmospheres. Okay. Стои така. And now we wait 1 minute, minute and a half. Някакви болки, госпожо? Окей. Сега трябва да се излъчи лекарството вътре от балона, така че ще изчакаме малко. You see we have a full inflation, there is no waste. So we will be waiting now for a while before we implant the stent there. Because we want to be sure that we have a full elution of the paclitaxel before we stent. To be honest, most of the time, if you have a critical stenosis of the subclavian, you have some backflow from the vertebral, and that gives you kind of a natural protection. But of course, there are some cases in the literature when you have some problems after the stenosis stenting of the subclavian. Fortunately, we didn't met this kind of problem yet. Keep. In this position, for us it's comfortable, we give it more time. Usually there's supposed to be 1 minute elution, but for the peripheral balloons, we rather go to a minute and a half or two just to be sure that we are fully eluting the paclitaxel.
In the peripheral interventions, there are two kind of ways to do it. First, put the DCB and then the stent, or first put the stent and then the DCB. I see that you adopt the first strategy.
For me, there is no reason to stent first. I think the elution would be less, how to say, homogeneous. If we put a stent, we'll have some metal.
Well, the idea is that the struts of the stent actually make some holes inside the plaque, and you can deliver the drug
Yeah,
deeper.
maybe. We'll check the result now. Госпожо, ще имате затопляне към ръката сега. I guess, as we expected, we have some small dissection. Of course, we will cover it with the stent.
Yeah.
And I will do a roadmap now. Имаме ли roadmap? Да. Okay. So I think we're going to stent now.
Yeah. What kind of
So I
stent?
will try to stent from the very ostium up to the normal segment. So that's why we decided we are going to choose a 4 centimeters balloon expandable stent, which is Restoral, the same company. Може ли стента?
What size?
8, да. 8. On the CT, we have a diameter of 7.3, and we believe the CT is somehow a little bit underestimating
I agree with that.
the diameter most of the time.
Are you going to protrude it a little bit in the aorta, or you try
I
to?
hope no. I hope no, but it's sometimes you may have 1 or 2 millimeters in the aorta. But it is not an osteal lesion, so I don't think we need a really nice protrusion inside the aorta in this situation.
Yeah.
We are relying also on the roadmap. I think it's a good starting point. We'll just check it. I even think we're a little bit too low.
Yes.
So we're going a little bit up. Something like this.
Yeah, it seems good.
So James, please go slowly 2 atmospheres.
1,
2, 3, 4. So we want to see some dog boning.
4.
There we go, up. Good. So we went up to 6 atmospheres. We'll keep it a while.
Yeah. It's well expanded.
It's already expanded, yes.
How long do you keep the inflation?
Something like 30 seconds, 30 to 40 seconds before we go down.
Do you check the inflation syringe if the pressure drops and then put it back to 6, or you, because sometimes happens.
Yes, we always do this. We first reach 6 atmospheres.
Go back. Yeah.
And then after it falls a little bit, we always inflate it again up to 6 atmospheres.
We're going to pulse dilate, adjust him somehow.
Do a flare.
Yeah, to flare a bit, yes. Awesome atmosphere.
We're up to 8 atmospheres.
Беги. Вляво. Изчезна ли? Боле?
So she
Изчезна.
had a little pain
A lady feels some pain with it, yeah.
during the pulse dilation. Now
It
we are
looks
down.
like we are overstretching a little bit the atria already. Махни roadmap. We'll push some contrast with the balloon still inside, just to be on the safe side. Okay, now we take the balloon out and we do a short angio for you.
Great result. Great.
I think we're doing fine, yes.
Yeah, yeah.
You see, because of the anatomy of the arch, we have more protrusion on the one side of the stent and less protrusion on the other side because it's the arch. It's not completely square, but we feel it's okay. So we'll now check the pulsation of the left hand. So we can, if we can feel it nice, we think that we are ready.
They were very diminished before the procedure. Very helpful.
Now we have a very nice and strong pulse on the radial.
Great.
Lucky
So we
lady.
believe in this way we have good acute results, and we hope that we will have also nice long-term result. And I think we are going to finish on this stage. Guys, do you have any comments?
No, I think you did a great job. Very clear
thank you.
indication. I have only one question. Did you discuss at least surgery?
No?
No.
Because it's a simple 20-minute procedure which gives you a very nice long-term and short-term results. Complications are very infrequent. We discuss surgery only in case of occlusion, if we feel that recanalization is too risky because of a chronic calcification and the lady is severely symptomatic. But in case of stenosis, we almost never discuss a surgery before.
Okay.
Great.
Okay, thank you guys.
Thank you.
Thank you.
See you again. Я не.
Не, сега има да презентация, не ги разменихме. Двамата въпроса, дали да е сега или след кафе паузата.
Ако искаш една сега, после кафе пауза и след това продължаваме.
Okay. Защото тази я няма. Фирмената презентация казаха, че я няма.
Няма ли я?
Да, и всъщност това е на място на Яновска излизам аз. После дали да бъде след кафе паузата или преди кафе паузата няма
И ти си избери. След кафе пауза.
След кафе пауза. Okay, let's have 10 to 15 minutes coffee break, and after that we'll continue with the presentations.